Okay, thank you so much. My name is Abby Varghese, and I'm one of the 3 pediatric urology nurse practitioners at Sick Kids in Toronto, Canada. I first want to thank Dr. Ansari and Dr. Yadav for including me in this topic of discussion and the chance to bring to light the practicality of providing these well-known recommendations to our families and how to encourage compliance for success. It's always nice to be at the end of the talk, especially after some great talks by Dr. Farhat and Dr. Prasenna, because it really kind of flows into what I'm going to be talking about. And it's the practicality for the nurses and what we need to do to be able to help the team to be able to allow for the BBD instruction. I do want to preface that these pearls are not unique to only my practice, but it has been incorporated by our team from the past, as well as presently under the direction of Dr. Dos Santos, and especially my nurse practitioner colleagues, both Mandy and Natasha, which some of the slides have been borrowed from their past presentation. When I first came to pediatric urology 12 years ago, I realized 2 things. Bowel and bladder dysfunction can be found everywhere, especially in areas of urology when you least expect it. And Dr. Farhat really made a good point. We all know that it can prolong a very simple consult into a 45-minute counseling session sometimes. Oops, sorry. And just when you think that you understand BBD, there's always going to be a case here and there that will keep you humble. So here are the objectives. This is only a 15-minute talk, and I just really want to highlight some particular topics, but I'm definitely happy to answer any questions through the presentation. And of course, the last couple of presentations really have touched base on a lot of the topics that I have in my presentation today. And really hopefully we can have some fun with it. So some interesting factors that I want to highlight today are what we face in clinic and how the bladder is affected by the fecal loading, especially in what parents describe as normal clinical bowel movements. We have also an antibacterial lifestyle that promotes a lot of incorrect toilet posturing from a young age, and that spills over to a delayed toilet schedule at school. And toilet training factors that may have influenced a future success in toilet training. This is a slide that I borrowed from my NP colleague, Mandy Rickard. Parents are often confused about the relationship between the bladder and the bowel. They question why we talk about the treatment of the bowel in their otherwise asymptomatic child for any bowel issues. And they cannot believe that healthy man-sized or as large as Coke can descriptions are in fact a spectrum of constipation. We do have Bristol stool charts to help classify the stool without bias. And here I found one in Hindi just for today's purpose. It is true that it would be really great to have these in clinic for the parents to actually look at so that they could describe this for us when we do our appointments. Often we do use ultrasound images that may have been put for the day to be able to use that as a point. And I print these off for families if they happen to have had an ultrasound so that they can see how it actually moves the bladder wall. But many parents then are still convinced that their child had not had a stool that day. And this is the reason for why it looks like this on the ultrasound. So although we don't like to do abdominal x-rays, I do have this image for an abdominal x-ray of a 7-year-old boy that we saw early this month in February, and he had chronic fecal incontinence, and I just took a snap just to be able to show you. We do explain to families that we are just one big long tube from mouth to rectum with little sphincters that are keeping everything in its place, and that some children can carry as much stool as a small baby in their rectum. That children who do not eat well, grow, or heal properly may actually see a change once we treat the fecal loading. And that a common reason for emerge visits is abdominal pain due to constipation. And lastly, that I've seen children in my career, unfortunately, that are so constipated, they're vomiting stool. And that ends up getting a very interesting response from the families. So although abdominal x-rays are not gold standard in diagnosing constipation, and as providers, we have to be very cautious about ordering unnecessary testing that involves radiation in young children, sometimes the pictures are in fact worth 1,000 words. It helps parents visualize that the extent of fecal loading is beyond the rectum, and it also guides us in a more aggressive or a more relaxed bowel treatment approach. We all know that proper posturing engages the relaxation process of the pelvic floor, but many parents do not know that hovering over the toilet can create dysfunction within the pelvic floor. Here in India, it is not uncommon to find westernized toilets, but you already have a better option. It's not uncommon for us to hear that the school bathrooms are dirty in North America, and hovering is likely learned from parental instruction as a toddler sitting on during toilet training. And this is to avoid sitting on public toilets. There is a big movement to mimic the Indian toilet by using stools similar to the Indian toilet by creating a squat position, and the popular company that Dr. Farhad had on his slides is called Squatty Potty. They're making a lot of money on things that we've been talking about for many, many years. Other factors to consider is that there are school practices like students accompanying each other to the bathroom or bullying behind closed doors that create a lot of holding practices for the parents. And this is just a kid-friendly version of it. To stem up the topic of toilet training, like Dr. Farhad had mentioned earlier, elimination communication is a holistic movement that has taken over in the last 2 decades in North America for a natural way of dealing with a baby's bathroom needs and future toilet training. EC is based on the idea that, like other mammals, humans don't like to sit in their own excrement. However, there is now a heavy reliance on diapers, and many people around the world still practice EC, especially here in India. I do have to say, even my own mother put my children in similar postures on her lap after they have fed to help them toilet. I don't know enough about this practice to say that it has a positive influence or not, but what I do know is that in North America, parents are looking for bigger and bigger diapers these days to manage older children who have not successfully trained day or night. So Dr. Farhad is hitting it on the nail with the studies that he's doing in Wisconsin. Is there a possible impact from our fast-paced lifestyle that insists on toilet training too early to be accepted into structured programs? An environment without support of an extended family that's creating this? Or the efforts that are being made with diapers that are going to wick away the urine so quickly that children have no clue that they are wet? Or just a very relaxed measure to avoid the topic altogether unless it's highlighted as an issue. Once a detailed history identifies the specifics of what is brought to the clinic and the opportunity to do a very thorough exam of the abdomen, genitals, and a basic neuro, we make sure that we use validated questionnaires like the DVSS score that Dr. Farhad had brought together many years ago, and the Vancouver scale to objectively diagnose and support our consultation. Most parents want to take a natural approach to treatment, but often they need more than just a directed prescription of pee more, drink more, have a healthy diet, take a stool softener. That's not enough for them. Once they're educated on the association between the bowel with the bladder, offering reasonable urotherapy goals that's going to work with a child's schedule and the parent's values are essential for the compliance. Toileting schedule every 2 or 3 hours based on a child's school breaks and activities. Coordinating stool goal of twice a day to have encouraged after meals to activate that gastrocolic reflex, and using an Indian toilet or a stool for the feet to improve that pelvic floor angle to straighten that puborectalis muscle. Toilet posturing demonstration in clinic for the V position for girls. Especially what I do is I actually sit on a chair and I show them how to be able to posture on the toilet, either backwards or forwards. And if you're wanting to rule out vesicovaginal reflux, actually show them how to bend down and wait and be able to tip so that they can eliminate some of that urine from the vagina. Pelvic floor dysfunction in children is often caused by constipation, UTI that creates guarding of the pelvic floor muscles, holding habits, ignoring bladder signals, and also obesity. So if needed, what we do is we refer to a pelvic floor therapist for non-invasive approach to therapy using pelvic floor exercises as well as biofeedback and TENS. Often I request families to have special toys at the toilet, and those are things like bubbles and pinwheels or feathers, and that really helps with the pelvic floor relaxation. Also something that our GI specialists at the hospital had recommended. High fiber diet is also calculated as for ages 3 to 18 by using age +5 to get the grams per day amount. I counsel the parents that each patient is individual and needs a variety as well as unique needs in comparison to their siblings because they are different people. The fiber requires more water to be effective, otherwise it will create more stool loading. And fiber supplementation are a choking hazard for small children. Good water intake through the day is better if it's structured along with this urotherapy schedule. Otherwise, they're trying to remember to pee every couple of hours, then they have to remember to drink, and oh, we have to go back to the bathroom to have a poop. That's all they're doing all day is peeing, pooping, and drinking. They don't have any focus for anything else. And this is what we generally use because parents also want a prescription on how many cups a day are they going to be able to drink as well. Lastly, it's really important to stress that the bowel treatment is the backbone of treatment for the bladder, and we cannot move forward unless we've been treated adequately. So all of the maintenance program of diet and supplementation and things like that are good for adjunctive and sort of maintenance in the future. But sometimes to be able to get where we need to get to, we have to treat. And although they don't like it sometimes, we have to really stress the use of some medication to be able to get some improvement in the bowel status before we can manage the bladder. I do recommend a variety of different options, whether it be through oral options, rectal options, bowel clean out options, all based on the family values. And you would be surprised, yes, although there are a lot of families who are not interested in rectum, there are families who are fed up enough that they will do the rectum. And there is a protocol in the US called the MOP protocol, where they do enemas every day and they slowly tight drain down the enema. And there are families who willingly go ahead and do it just to manage the enuresis or the daytime wetting. I do offer magnesium supplementation as adjunctive because it is a mineral and it has an important role in muscle relaxation, and parents are often really engaged to want to do something natural like this. So how many of you experienced this scenario as a parent or heard this from a family? It's the fun game of finding out the flavor of the day to entice a child to pee when they don't want to go. They go through all of these options of maybe direct instructing, fun ways to go pee, bribery, appealing to the child's better nature, or just plain peer pressure. The important thing is to help parents understand what works today may not work tomorrow. It may not even work in 2 hours. I explained that this is a team effort, that we are all valuable players to the BBD program, and how the involvement as an impact as providers and parents are good, but the MVP is the child. So they need to be engaged for this to work. Oh, where'd it go? In the end, we all take the win, but we must know that when we need to back off as well. And if needed, as suggested, using social work on our team is really essential to be able to help with the psychosocial counseling. More so, I find, for the parents, because the children sometimes don't really care. This is an image of a bladder retraining video that my NP colleagues, Natasha and Mandy, had created a few years ago that is very popular for the young children. We ask families to use stickers as incentives to follow a schedule and not actually the success of being leak-free. Short timelines with incentive celebrations that can be like mini gifts, a child's choice, an activity, or even dedicated time with a parent are all very good, especially in those with multi-children in families, to be able to have the incentives that they need to have recycled to avoid the boredom of these fun things as well. Use of fun Dixie cups to reduce the daunting nature of having a very large water bottle that they have to drink, especially for children who don't like to drink, or to remind them to drink on a schedule right after they pee to keep on track while they're at home. And also to keep on a positive track for the stressful part in their life. Some kids need humor. So here's an image of an ad for a poop cafe in Toronto, where poop comes to life in form of a dessert. You've got toilet seat bowls that are eaten out of, and one can even sit on a toilet seat stool. For parents, we instruct monitoring with various tool options. Overall, we provide pre-prepared letters for families for school engagement to be able to provide an outline that the child is a patient of the hospital and is required not to have a barrier in following a timed voiding schedule and allowance for any kind of urge requests that they may have, to support also reminders without drawing attention to the class if that's possible. For the bowel, we use the Bristol stool chart as I showed before, and there are lots of kid-friendly options to be able to keep them engaged at home. The footstools, as I had mentioned, bladder diaries, which could be in app or paper form. We do prescriptions for mainstream vibrating watches because the kids these days, they don't want just a regular watch. They want an Apple Watch, they want a Fitbit, and especially so that their friends don't actually see that they're following something that is quite unusual. Nobody wants to go to the store and have a small little toilet on their arm to be able to highlight to them why they're actually following a schedule. And then toilet posturing techniques, like I said, I demonstrate in the clinic so that way then they know exactly how to do this. This is very hard though when they're at school. So I only ask them to do it when they're at home, because if you have to take your underwear and pants off and sit backwards on a toilet, no one is going to do it at school. So especially when they're doing a voiding diary, they do it for 2 or 3 days. It's really essential to be able to do it at that time to be able to identify if associated there is vasovaginal reflux as well. Online, you can find fun or clear water bottles. This one that I have as an example has like motivational sort of highlights on it to be able to help. But it's nice to have a clear water bottle with some titration sort of points to be able to encourage the children to be able to drink at a certain level, as opposed to drinking a large volume. When parents send off a bottle and say, you must drink this within a short period of time, 3 o'clock, the bell rings and the kid thinks, oh my gosh, I haven't drank anything, and then drinks the whole entire water bottle and is like frequent every 15, 20 minutes after. And it's because they're trying to avoid getting in trouble by their parents. We often see this in the clinic as well. We ask them to do a Euroflow study and they're peeing every 15 minutes while they're in there for the consult. And that can encourage a lot of maybe small capacity Euroflow studies because they're voiding so frequently and they need to urgently go. And then antibacterial sort of topics come up. We ask them to use disposable toilet covers or toilet seat reducers for the really young ones, antibacterial sprays or wipes, which are now readily available because of COVID, and then simply lining the toilet with toilet paper. In the end, we do say, as soon as they come home from school, just have a shower, and then all of the mismanagement that happens is done. And at the end, we did create an online instruction video for parents to review what we've discussed in clinic. And thank you.